hello there, everyone. Welcome back to another episode of the NPTE Explained. My name is Lily. I'm a neurologic physical therapist, and I'm also a professor at the University of Texas at El Paso. And if you know me, if you've seen me before, I am the Brain PT. So, the Brain PT, if you don't know, it's a social media resource that contains a bunch of videos in topics of neurologic physical therapy. So, today we're going to be reviewing questions of the typical PT platform. And if you're preparing for the NPTE exam or just curious about what makes these questions up, you're in the right place. So today we're diving deep into the questions, breaking them down, analyzing them, and just giving you tips on how to tackle them like a pro. So grab your notes, get comfy, and let's get started. So this is the first question that we're going to review today, and I'm going to read it to you. So in an acute inpatient rehab facility, a 65-year-old female with a recent ischemic stroke affecting the left cerebral hemisphere presents with right-sided facial droop, dysarthria, right hemiparesis, and aphasia. An MRI confirms a recent infarct in the left middle cerebral artery territory, so left MCA, and his NIH stroke scale is 12, indicating a moderate impairment. In managing this patient's post-stroke rehab, which of the following interventions is not considered a facilitatory technique? So the answer choices are A, performing resistance exercises, B, performing Bobath's technique, C, performing a quick stretch, and D, performing a prolonged stretch. So we're looking for something that will facilitate movement, cause movement. So by knowing that, we can explore the answers. So A, performing resistance exercises. This will recruit motor units, therefore it can facilitate that motor recruitment and motor activity, right? B, performing Bobath's technique. This is an old technique used in the past to facilitate movement. Performing a quick stretch. A quick stretch is a way to facilitate as well, like used in the old PNF. And then performing a prolonged stretch. If you know, prolonged stretch can be used to inhibit, especially when someone has increased tone. A stretch can be done to decrease. So I'm going to go with D, performing a prolonged stretch. Now, a disclaimer here, we're both learning, so I don't know if I'm going to get it right. So if I get it wrong, again, we're all learning. So let's try D. Okay, so D is the correct answer. So performing a prolonged stretch is correct because it is not typically classified as a facilitatory or facilitation technique. I know it as facilitation in stroke rehab. Prolonged stretch is primarily used for managing spasticity and preventing muscle contractures. So again, these is an inhibition technique. Okay. Next question. Okay, a 55-year-old male patient diagnosed with ALS is currently receiving pharmacological treatment with riluzole. During a physical therapy session, he expresses concerns about increasing difficulty in swallowing and occasional choking episodes. Working alongside the rehab team, what intervention should the team work on to address Mr. Anderson's swallowing difficulties in the context of ALS? So here for this question, you need to know the disease process of ALS. So you know that ALS is a motor neuron condition that it's going to get progressively worse. Therefore, you're going to see weakness as the disease process continues, right? So one thing is we want to avoid intense exercise with people with ALS, but we can definitely exercise to maintain the strength. So here we're going to look at the answers. A, implement oropharyngeal exercises to improve tongue strength and coordination. B, recommend a soft diet to minimize the risk of choking during meals. C, administer neuromuscular electrical stimulation to the throat muscles for enhanced coordination. And D, implement chin tuck posture techniques during meals to minimize the risk of aspiration. So here from the get-go, we can cross out some not ideal answers. So the first one that stands out is B. We cannot recommend changes in the diet, right? So we can delete D from the equation. Also, I think C, just doing, I don't know what is the approach that speech therapists utilize, but electrical stimulation in the throat muscles, they're already really fragile and very thin. So I would not utilize this technique for someone with ALS, or not that I know of. Then implementing chin tuck posture exercises, if anything, is going to kind of close up some of the tracks here on the throat, and so it just doesn't seem like the ideal approach. So therefore we're left with implementing oropharyngeal exercises to improve tongue strength and coordination. Now, even if with ALS you're not necessarily going to improve the strength, we can maintain the strength. So from all these answers, the ideal one seems like it is A. So let's take a look. Okay, so that is a correct answer. So implementing oropharyngeal exercises to improve tongue strength and coordination is the right answer. So in ALS, the progressive degeneration of motor neurons can lead to weakness in the muscles involving in swallowing and the tongue. So the oropharyngeal exercises will target the tongue, helping maintain or improve strength and coordination. Okay, now the one that we're thinking about, the chin tuck is a useful technique, but for ALS, these muscles are already too weak, especially the neck muscles are already too weak to do a chin tuck. But in other situations, chin tuck is a good technique for other people without ALS. And also, I would wonder, because that chin tuck does feel a little unusual, if if you're trying to minimize aspiration. I don't know, deeply this topic of what exercises help to minimize aspiration. Perhaps this is a topic that you can explore to open up that knowledge in that area. So, full disclosure, I really don't know much about exercises to improve or minimize the risk of aspiration here. Now, the other one is, of course, the administering neuromuscular electrical stimulation. It is a valid, right? And I've seen speech therapists do this, but I don't know if it's the first choice for someone with ALS. Okay. Last question. So, a child with a protruded growth. Okay, so here we have some pediatrics. I'm not super strong in pediatrics, but let's take a look. With a protruded outgrowth of the spine. So here we have a spina bifida, right? Presents with motor loss below the level of the defect in the spinal cord. The child demonstrates sensory deficits, hydrocephalus, and scoliosis. What will be a key focus of physical therapy intervention for this child? Answer A, implementing aqua therapy to address sensory deficits. B, emphasizing family education on positioning, handling, and therapeutic exercise. C, using joint protection strategies. Or D, prescribing orthotic devices for clubfoot correction. Okay, so here we have a question about someone with spina bifida and what is the best approach in physical therapy. Now, here we see a bunch of interventions that are, can be appropriate, but which one is the best one? So, aquatic therapy, yes, can be a good focus in someone's rehabilitation in spina bifida, but it doesn't seem to be the key focus in the physical therapy intervention for this child. So the next one, B, emphasizing family education and positioning, handling, and therapeutic exercise, seem like it's a really good option. C, using joint protection strategies. So this is, I would say, if the child is not moving too much, then I would consider this one as well. And prescribing orthotic devices for clubfoot correction. Although this question doesn't necessarily tell me a lot about clubfoot, so I'm wondering if B, emphasizing family education on positioning, handling, and therapeutic exercise, is the best choice. So let's take a look. Okay, so that's the right answer. Answer B, emphasizing family education on positioning, handling, and therapeutic exercise is the best position. Okay, so now A, again, aquatic therapy, it's beneficial, but it's not the primary focus. C, joint protection strategies are not the primary intervention for spina bifida, and especially if the child is able to mobilize a little bit, right? We don't know the extent of the motor loss below the defect. So here we don't have a lot of information about that. And D, while orthotic devices may be prescribed, they're just not exclusive for clubfoot. And we do not know, what's the extent of clubfoot in this child. So that's why it's probably not the right answer. So that's it, guys. Thank you so much for listening to another episode of NPTE Explained, and check out the description for any additional resources. Bye for now.